A heart attack, clinically called a myocardial infarction, is one of the leading causes of death in the world, claiming nearly 9 million lives globally each year. But a heart attack is not a sudden random event. It is almost always the end stage of a process that has been developing silently for decades. The progressive buildup of fatty plaques inside the coronary arteries, the blood vessels that supply the heart muscle itself with oxygen. This process is called atherosclerosis, and it begins not with calcium deposits or blockages but with damage to the endothelium, the delicate single-cell thick inner lining of the artery. Risk factors including high blood pressure, smoking, high LDL cholesterol, diabetes, and chronic inflammation damage the endothelium, allowing LDL cholesterol particles to penetrate into the arterial wall, where they become oxidized and trigger an immune response that sets atherosclerosis in motion. Once LDL particles enter the arterial wall and become oxidized, macrophages, the immune system's cleanup cells, rush to the site and engulf the oxidized LDL. But the macrophages cannot effectively process large quantities of oxidized cholesterol. They become engorged and transform into what pathologists call foam cells. These foam cells accumulate, die, and deposit their lipid contents into the arterial wall, forming what is called the lipid core of an atherosclerotic plaque. Smooth muscle cells migrate to the site and lay down a fibrous cap over the lipid core, a kind of scar tissue. This fibrous cap is what determines whether a plaque is stable or dangerous. A thick, stable plaque may narrow the artery and cause predictable chest pain on exertion, known as stable angina. A thin-capped plaque, rich in inflammatory cells and soft lipid, is vulnerable to rupture. Plaque rupture is the event that converts years of silent buildup into a life-threatening emergency. When the fibrous cap tears, the lipid core of the plaque is exposed to the bloodstream. Platelets immediately recognize the exposed lipid and collagen as a site of vascular injury and begin adhering to it. More platelets are recruited, they activate and aggregate rapidly, and the coagulation cascade is triggered. The result is a thrombus, a blood clot, that forms on top of the ruptured plaque. If the thrombus is large enough to completely occlude the coronary artery, blood flow downstream stops entirely. The heart muscle supplied by that artery is immediately deprived of oxygen, a state called ischemia. Without oxygen, the energy-hungry heart muscle cells begin to die within minutes. Every minute of complete coronary occlusion kills approximately 2 million cardiomyocytes. The clinical distinction between a STEMI and an STEMI refers to the pattern seen on an electrocardiogram, the ECG. A STEMI, ST elevation myocardial infarction, shows characteristic elevation of the ST segment on the ECG, indicating complete occlusion of a major coronary artery and full-thickness heart muscle death. An STEMI, non-ST elevation myocardial infarction, typically involves partial occlusion or spontaneous clot lysis with resulting partial muscle damage. Blood tests for a protein called troponin are central to diagnosis. Troponin is normally confined inside heart muscle cells, but when those cells die their membranes rupture and troponin leaks into the bloodstream. Rising troponin levels, detectable within hours of the event and peaking at 12 to 24 hours, are the biochemical signature of heart muscle death regardless of ECG findings. The classic symptom of a heart attack is crushing chest pain, often described as pressure or a heavy weight on the chest, radiating to the left arm, jaw, or neck. This radiation pattern occurs because the heart shares spinal cord segments with these regions. The pain signals travel along shared nerve pathways and the brain misattributes the source, a phenomenon called referred pain. Associated symptoms include diaphoresis, profuse sweating from sympathetic nervous system activation, nausea, vomiting, and shortness of breath. Women, people with diabetes, and elderly patients often present atypically, fatigue, jaw pain, nausea, or back pain without prominent chest pain, which contributes to delays in recognition. The internationally recognized performance standard for STEMI treatment is door-to-balloon time under 90 minutes, the interval from hospital arrival to restoration of blood flow via percutaneous coronary intervention. Restoration of blood flow to the ischemic heart muscle is the only intervention that limits infarct size and preserves cardiac function. In primary PCI, percutaneous coronary intervention, an interventional cardiologist threads a catheter through the femoral or radial artery, navigates it to the blocked coronary artery, and deploys a balloon to compress the thrombus and plaque, then places a metal stent to hold the artery open. In settings where PCI is not immediately available, intravenous thrombolytics, drugs that enzymatically dissolve the clot, can be used as a bridge. The principle underlying every aspect of heart attack treatment is captured in the phrase time is muscle. The faster blood flow is restored, the fewer cardiomyocytes are lost, the better the patient's long-term cardiac function, and the lower the risk of heart failure and sudden cardiac death in the years that follow.